Hi, and welcome to the Breastfeeding Medicine Podcast. I'm your co-host, Dr. Ann Eglash. I'm a clinical professor in the Department of Family Medicine at the University of Wisconsin School of Medicine and Public Health and a board-certified lactation consultant.
And I'm your co-host, Dr. Karen Bodnar. I am a pediatric hospitalist at Inova Children's Hospital and an assistant professor of pediatrics at Virginia Commonwealth University.
I'm also a board-certified lactation consultant.
This podcast is produced and edited by the Milk Mob and is co-sponsored by the Academy of Breastfeeding Medicine. Are you ready to go?
Good. How are you?
Good. So we're going to talk about a couple things today. First, I want to talk about the upper lip frenulum, which I think many of us are hearing more and more about. You and I really haven't talked about tongue ties, so this will be a fun new journey for us. Yes, and unfortunately there are so many sides to this issue that it's almost frightening to get involved.
Well, yeah, I think there's a lot of different opinions about it.
Lots of experiences, yeah. So the article that I'm going to review is entitled "The Superior Labial Frenulum, What is Normal?" And this was done by Chloe Santamaria, Janelle Abbey, and others, which was published in the Global Pediatric Health Journal in April of 2017. And this was a study that was done at the Lucile Packard Children's Hospital at Stanford in California. So just to be clear about what we're talking about, the superior labial frenulum is that soft tissue that attaches the upper lip to the anterior surface of the upper gum, or what's called the maxillary gingiva. So if you stick your finger above your two front teeth and feel that piece of tissue, most people have that piece of tissue intact, and it feels like a frenulum.
I can't feel mine. Mine got clipped when I was 9.
Oh, you had yours clipped. Oh, okay. Well, that's really a loaded issue right there. But we're going to talk about that in just a second. Many people are now calling this lip tie, particularly lay people, and some lactation consultants are calling it lip tie. But I have to admit that I have a tendency to say, no, it's a frenulum, just like the ear is not a thing that hangs off of our head. It's an ear. So this is something that, and so this study actually validates that, because we'll talk about how they basically found that every baby they studied has one of these. So anyway, although this is a study, I just want to first give some background that the authors shared. So first, they state that there's little evidence that the appearance of the upper lip frenulum has any bearing on latching or feeding, although we know the evidence has become stronger that the tongue ties, the lingual frenulum, can play a role in effective feeding. Now, I know that people who may be listening will say, well, wait a minute, I know the upper lip frenulum plays a role because I've seen clippings happen where babies and mothers, have improved their breastfeeding, and that's fine. And we can talk about that at the end of the study, because I understand that. But there's just not a lot of evidence. They also explain that the frenulum does look different depending on the age of the child, and that younger children, like babies, their frenulum oftentimes looks pretty broad all the way down to the base of the gum, whereas as the child ages, that frenulum will essentially become less prominent and rise up higher. So we don't see, if you look at babies, if babies could smile really broadly, you're right, and with their upper lip grinning, really like pulled up, we would see that frenulum right there where it lands, where you would think the two front teeth would go. That's super common. But if you don't see that in adults or, elderly with dentures, if they take out their dentures, you don't see this big frenulum like they have in babies. So it just looks different because it rises up. So there are some babies, though, that do have trouble with their frenulum, and that may have been you when you were a child, because sometimes they do stay attached to that alveolar ridge where the teeth come down, and sometimes the frenulum will separate the two front teeth, and that's called a diastema. And the authors state that a diastema is really considered benign and in most cases doesn't need to be operated on. But some dentists are concerned about them because it can be associated with periodontal disease, because food can get trapped between the teeth and the frenulum. or perhaps have an issue with the spacing of those two front teeth. So,
Yes,
but
I think my mother's concern was purely cosmetic.
oh, cosmetic. Okay. Well, I would say that in my practice, as a family medicine doctor, and I do tons, half pediatrics, I would say since 1994, I've probably had one child where the dentist wanted to clip it, when their teeth were coming in. So not very common in my neighborhood. So many people who may be listening have heard of Dr. Larry Kotlow, who's a dentist, and he did a categorization of lip frenula into grades 1 through 4. And so grade 1 is where it attaches to where the mucosa and the gingiva meet. So that would be like kind of halfway down of that upper gum. Grade 2 is where it attaches further down, but not really at the edge of the alveolar ridge where the teeth come out, but close to there, like in the front of the gum. And then the grade 3 is where it attaches to the edge of the gum where the teeth come down. And then grade 4, it wraps around and it attaches to the hard palate, to the underside. And the idea, with this grading, is that the higher the grade, the higher the severity, so to speak. And the concern is that maybe these frenula are preventing the upper lip from flanging around the breast, and so then it's considered tied down. So the goal of this study was to describe the typical appearance of the upper lip frenula in a bunch of babies and to see how this classification system worked. So they recruited babies from the newborn nursery, kind of first come, first served. They took the first 100 babies of the families who consented, and they took these high-res photos of the frenula, and the main thing that they recorded about the babies is their ethnicity and their gender. So they took 6 raters, people who would who would look at the photos and rate the frenula, including 3 pediatric ENTs. 2 were attending ENTs, and 1 was a resident. They also had a newborn hospitalist like you, 1 pediatric dentist, and then a lactation consultant. So they rated the frenula according to the Kotlow system, and every rater rated each frenula twice, and so they were like reshuffled, and then they looked at them again. So they didn't know like how they rated one, like if they rated A, they rated A again, but A was not labeled as A, so they didn't know what they rated it before.
Interesting.
Yeah.
Check the consistency.
Yeah, the intra
within the rater. Yeah.
Exactly. Yeah. And so basically, every frenulum was rated 12 times. 60% of these babies were Hispanic, 22% were Caucasian, 11% Asian, and 5% African American. And that doesn't come out to 100, but there's a few various other ones. So basically, they found that 100% of these babies had an upper lip frenulum, no question. 6% were rated as grade 1, 41% were grade 2, 39% were grade 3, and 14% were grade 4. So this means that the majority were grade 2, 3, and 4, and those all connect to the gingiva, to the upper gum. So this means that the great majority of these extended down to either the edge, close to the edge, or at the edge, or beyond the edge of the upper gum. But they also state that the raters had pretty poor intra and inter-rater reliability. So there was a poor distinction between the raters, between the grades 2 and 3, and only 8 babies out of the 100 had the same rating for all 12 evaluations.
Maybe they should have only had 3 categories.
Well, you know what? You are brilliant, because that's exactly what they discussed. Is that really that is so great. I love that comment. Yeah, that's exactly what they decided. I wasn't even going to
thinking about doing it. Like, if I was doing that, that's where I would have trouble, right? Like, is it just halfway, or a little more, or a little less?
Exactly, right.
Problem with definitions like that. I rarely have calipers when I'm with a baby.
Right. So their thought is that you basically combine the 2s and the 3s, and then you have the 4s that are really severe that go wrap around. And then they found that only about 64 to 70, between 64 and 74% of the time, did one rater grade the one, like a frenulum, the same each of the 2 times.
And this is photographs. It's not like the baby's moving around, right?
That's
Like,
another great comment because that's exactly what they said in their summary. Is like, hey,
I
these are high
swear I did
res.
not read the summary.
But that's the thing is that these are high res photos. So think about like our labor and delivery rooms or our our postpartum rooms are dark. They're kind of like the sultry lighting, so you can't really see that well. And some of the evaluations, of course, are happening in doctors' offices where the lighting is better. But still, it's a lot different having a high res photo versus a squirmy baby who's really hungry and mad at you for
Or who's
messing.
completely sound asleep and you're like, prying their mouth open.
Yeah, exactly. They tighten it. Yeah, exactly. They basically say that, first of all, because these are normal, that everyone has one, we should not be calling them ties, because ties imply that these are abnormal. Which I totally agree, and I try. That's like my soapbox when people come in and say, "I just want to check this lip time." Like, okay, wait. First of all, let's not even call it a tie. And then, in addition, they say that the Kotlow system is not reproducible or accurate, and they recommend going to a three-graded system. And then they didn't even talk about treatment because treatment is a whole nother story. Like, how do you treat?
Yeah, that wasn't what they were
No,
evaluating.
no. But I would say that. Like when people ask me, do I, should we clip this? I think it's a mistake to, if a baby's having a frenulum clipped, a lingual frenulum clipped, to automatically just do the upper lip frenulum. And we don't really know
Well, that's the
the outcome of
problem,
that.
right? Is most of the research has to do with babies where both were done. There isn't a
Right.
lot of independent study of just having the lip frenulum
Yeah,
clipped.
yeah. So, I do see some babies where I think it's reasonable to clip it. So, the things that what I tell families are basically two criteria. One is if there's pain at the areola where that upper lip hits, no matter what position they're in, they can feel the pain and the pressure because there's pinching right there of that upper lip because it's tight. And the other is that there's milk leaking from under the upper lip. Because they can't get a good seal because it's kind of just tacked down in one area. Those are
Hmm.
really the two things the two recommendations the two criteria that I recommend to like our peds ENT people, because they get a lot of questions with people coming and saying, I want you to clip that upper lip, but we don't know, is that going to play a role with how they smile, how their upper lip moves when they're older? We don't know whether or not this is appropriate.
I mean, I think it's hard, partly because, this isn't an area that medical professionals get much training in. For instance, my son, who is 7, has, his adult front top 2 incisors in, and they're sort of a little bit sticking away from each other.
Hmm.
And my mother, who's clearly concerned about this issue, said, "Oh, you should have the dentist look at his, frenulum there." And so, being a good daughter, I asked the dentist, I said, "Is this something I should worry about?" And she said, "This is developmentally appropriate because as his adult teeth come in on the sides of his incisors, they're going to push those teeth together." And so I just had this moment of like, wow, how as a pediatrician did I never learn that that is a normal developmental stage as children's teeth come in?
Right, right, exactly. Yeah. Yeah, and if you think about it, kids have like such wide spacing, they don't even need to floss when they're really little,
Yeah, yeah.
right? And
Otherwise, they're going to
then
need braces when they get older, like I did, because mine were too close.
exactly, yeah. And then I think I read somewhere else that there's no evidence that clipping the frenulum early is necessarily going to make a difference in dental spacing later. Um, so so that's the other thing is that I think some people think, oh, look at how broad this is.
Oh,
We need to get a
yeah,
clip
that's really
now
interesting because it naturally moves up. And
because
and
it
that
naturally
goes
moves
to
up, right?
questions I get a lot about, you know, tongue tie when we have a really anterior tongue tie and people are concerned about it, but they're not breastfeeding, and whether or not that's going to affect speech later. And
Yes.
it,
People are
it's
becoming
hard
more
for me
concerned
to
about it.
give really solid answers. I think this is an area that is going to continue to be a hot topic until we have more research.
Right, right, absolutely. All right, well, there's one other topic I want to talk about, and that is the effect of, it's an article entitled the effective pumping pressure on the onset of lactation after cesarean section, a randomized controlled trial. And this was a study that was done in Shanghai, China, by the first two authors are Feng Zhang and Yahui Yang, and I'm sure that that's not really how they're pronounced, and others. The authors point out as a background that cesarean birth is associated with early cessation of exclusive breastfeeding and any breastfeeding, which is a problem because in China, up to 60% of births end up in cesarean section, depending on the area of China. And worldwide, about 30% of births now are via cesarean. And as a matter of fact, before we got online together, I was listening to National Public Radio, and there was a piece on cesarean birth in Mexico, and they said that 64% of births in Mexico are via cesarean. So it's not just a problem, obviously, in China. And so previous studies have shown that suction pressure is related to volume, and we know that that's true from some of the pump studies and some of the studies that are done with infants checking suction pressures and seeing higher milk volumes. This particular group of authors, they also published previous research showing that babies born via cesarean have weaker suction pressures compared to infants who are born via vaginal delivery. And babies who are born via vaginal delivery, who are healthy, term babies, they tend to generate pressures of negative 150 millimeters of mercury, and babies who are born via cesarean tend to generate pressures of about negative 100. And in their research, they were actually able to tease out that the lower sucking pressures were related to the delay in onset of lactation or secretory activation, that these lower sucking pressures were related to insufficient milk supply, the time to first feeding, the prolactin level, cracked nipples, and the degree of supplementation. So their theory is that those lower sucking pressures seems to be the bigger issue. Like, I think a lot of times we think about when women have a cesarean that there's all these other factors like maternal stress and surgery and pain meds and magnesium and all this other stuff. And they're saying, well, maybe this is all happening because of lower suction pressures. Although I have to say, in this research, I didn't talk about this, but in this body of research that I'm going to present, they didn't really talk about the management of the mother via C-section. Like, did she have general, or did she have an epidural?
Why did the babies have lower sucking pressures if they were born by cesarean? And was
Yeah.
it related to all those other factors that we were thinking about?
Right. So anyway, this study was done at a baby-friendly hospital, and they recruited women who had a cesarean who didn't have any underlying medical problems associated with a delay of lactation. So anyone who had obesity, who had preeclampsia, gestational diabetes, anything like that, they didn't include them because they know that those are independent associations with a delay in lactation. So they put people into three groups. They had the high suction group, where they had these women pump every 3 hours with a 4 to 6 hour break at night with a pressure of negative 150. And then they had a similar group who pumped the same frequency with a pressure of negative 100. And then they had a control group that didn't pump unless the baby went to the NICU. In all three groups, the babies could nurse whenever they wanted, and any milk that they expressed from the pump was given to the baby. Once the milk came in, they stopped pumping, and they defined the onset of lactation as when the breasts were feeling pretty full. At that point, and then at day 4, so all these mothers stayed until day 4, and on day 4 they measured how much milk they were able to express, either like adding up how much the babies took via breastfeeding and how much they expressed via pumping if they were pumping too.
Did they use test weights to figure out how much the babies were feeding?
Right. So their outcomes were onset of lactation. This is what they were measuring. Onset of lactation, the mother's milk supply. They measured prolactin levels at 24 hours. And then the mom's satisfaction with how things were going overall in terms of their milk supply and feeding. So the prolactin level was done at 24 hours. They did a before and after feeding prolactin level. So they ended up with 148 women, and the results showed that the women who pumped at the negative 150 millimeters of mercury had onset of lactation 6.8 hours earlier which ended up being at around 52 hours postpartum. So approximately 7 hours earlier than those who used the negative 100 millimeters pressure. Their milk came in around 59 hours, and the control group, their milk came in at around 70 hours. So it was like this huge difference, like an 11 or 12-hour difference from those who pumped with negative 150 versus those who didn't pump at all. And they said that there was no difference in how frequently the babies nursed in any of the groups. They all nursed about the same frequency. They also found that the group that had the higher pressure had higher rises in prolactin, like the change in prolactin level before and after feeding or pumping was higher than the lower suction group. And then the lower suction group had a higher prolactin response than the control group. And then they looked at volumes, and they found that the mothers who pumped at a higher pressure had more milk, and they had more milk than the lower suction group, who had more milk than the control group. And in general, they found that the mothers who were given pumps early had more satisfaction with their supplies in comparison to the controls, although the mothers who had the highest suction pressure had more nipple pain. And they asked to have the pressure, some of them had asked to have the pressure reduced. But they didn't zoom it up right away. Like they took 3 to 4 minutes to get it up to the negative 150. They didn't you can cause damage, right, if you just stick it on at negative 150.
Ow.
Yeah.
Okay, wait, I've been dying to ask you for several minutes now about because in my experience, all the hospital grade pumps that I've used, they have like a percentage on the dial for the suction, right?
Right.
So is this like 150 is like all the way? It's like 100?
No, usually not. They had a pressure gauge connected to the pump, so you could actually just make sure that the pump was
I
at
really
negative
want to get out
150.
my pressure gauge and go see what percentage that is on some of my hospital grade pumps in
Yeah.
my hospital now, because I find that a lot of moms get started pumping with really low pressures
Right.
where I am. It drives me nuts.
Right. I think it's a big mistake. I think they say, oh, just pump to comfort, and the mothers, of course, are going to choose the lowest pressure, right? And think, oh, I'm doing fine, and you don't even see the nipple
This
move.
study is blowing me away.
Yeah. Well, the thing is, I've been using my gauge now for several years, and I can look at a pump. Like I pretty much know with the Symphony and the pump and sound and Spectra exactly where the negative 150 is and where the negative 250 is, and so I can just say, no, this is where you need to go. So it doesn't take long to learn that. After using it consistently with pumps for about a month, I was able to figure out, just to remember where it is.
Yeah,
Um,
that's fascinating.
Yeah, but the other thing is that they did measure infant sucking pressures. All these babies were born via cesarean, and they found that the typical sucking pressures in this population was negative 100 to negative 98 to negative 117, which is lower than the studies that are done of babies who are born vaginally. So this body of research looking at the sucking pressures was similar to their previous body of research showing pretty much the same sucking pressure in babies who are born via cesarean. So they feel that those weaker pressures generated by these babies born via cesarean may lead to the late onset of lactation and lower milk volumes. So, but they also warn like more is not better. So if you go past the negative 150, that could backfire, right? Because people have more pain and then they don't let down and it causes trauma. So you really do want to be careful with how much pressure is being that's being increased. The other thing is they say that, in conclusion, that really if moms are being separated from babies, that we really do want to make sure that they are getting to that proper pressure. And I would say this has become a little bit of a soapbox for me too when I see moms who are referred to me and the baby's still in the NICU, and I look to see what they're doing with their pumps. Because they're seeing me for low milk supply, one of the first things I'm doing is just adjusting things. And many times they're coming to me saying, well, I can't get it up very high because it hurts so much. And then I realize, well, you need a different shield,
Yeah, it's not the right size.
Right. And sometimes it's not the right pump because, if you listen to the pump cycles, some of them have different,
Yeah, absolutely.
suction, what's the curves, I guess you would say. So
yeah, when we had the 3-day physician course and you brought all the pumps, and I was fairly experienced, but I hadn't had them all side by side and listened to if they're like purring like a kitten as they go
Yeah.
up versus sort of ver, ver, ver,
Yeah.
ver on off. And that can really affect how it feels.
Yeah, yeah. I mean, I think everyone has different, just like everyone likes to be touched differently. Everyone's going to respond maybe with a different cortisol level depending on how abrupt or how smooth, that suction is. I heard recently that the Purely Yours pump, for example, Amida, which is a very nice pump and it generates nice pressures, they recently changed their cycle so that it's not like the boom boom. It's more like it's a softer rise, a
Smoother.
softer, yeah, maybe a little bit more like a slightly longer duration at the peak. At the peak, I'm not exactly sure what the difference is, but I've heard it's more user friendly and it's quieter as well. So even those little differences may play a role in how women respond to a pump. But anyway, I thought it was good. I think the big message is just making sure that when women are pumping, that's the baby at that time, and we need to make sure that baby's working as well as a healthy term baby would, making sure that it's generating sufficient pressure.
Absolutely. And
Yeah,
that goes back also to the fact that moms who have late preterm babies often need to do something aside from just putting the baby to the breast because those babies just aren't as strong.
right, exactly, right. Sometimes they just need to, right, especially if they're right. And actually, what our protocol at our hospital for the 35 to 37 weekers is to pump in addition to nursing. And then the question is, well, sometimes these babies are really good nurses, so do we really need to do that? Well, yeah, we probably should, unless we're putting transducers in their mouths to look at their pressure. It's probably a good backup thing to do
Yeah.
to really get things going. But then we also have to listen to moms. So like I had a mom a couple months ago who had a history of a very high supply with her first baby, and then her second
Yeah.
baby ended up in the NICU. So when she started pumping, she said, I don't think I should pump like every 3 hours because I make a lot of milk. And lo and behold, at a week, the staff said, no, you really do need to because you have a preemie.
Uh-huh.
Well,
I've
at a
heard this
week,
story
she was
from several different people, and then she had too much.
and she had 80 ounces a day. Yeah. And
Oh,
then she came to me like,
gosh.
I am having a nightmare here because I don't know, I can't seem to
It's too
reduce my
much.
supply. Yeah. And then her body doesn't listen to the fullness and then she can't back down. So then she needs
Mhm.
medicinal intervention. So then there's that problem too. So we have to always keep it in balance, right? So,
Oh, so much to do.
so much to do. All right, Karen. Well, it's great talking to you.
Those
And
are awesome. I can't wait to talk to you again.
yeah, we'll talk soon. Okay, take care. See ya. Bye.
Bye.
For questions regarding this podcast, contact us through themilkmob.org. We have other educational projects going on there, such as the Clinical Question of the Week and our Outpatient Breastfeeding Champion programs. If you want to see what we look like, check out our Facebook page, where you can also share comments and questions with your co-listeners. To learn more about the Academy of Breastfeeding Medicine, please visit www.bfmed.org. Thanks for listening. We'll be back with you in a few weeks.